Hello and welcome to Digest This, where we focus on day-to-day clinical issues in gastroenterology. I'm Elaine Robertson, a gastroenterology consultant in Lanarkshire. Today we're discussing thrombosis in cirrhosis, and I am delighted to welcome Dr. Stewart Campbell, my colleague in Lanarkshire, also a consultant gastroenterologist with a special interest in liver disease. Welcome, Stewart, and thank you for joining us today.
Hello, and thank you very much for asking me along today.
Now, when we think about patients with cirrhosis, we more often think about bleeding complications rather than thrombosis. Are we wrong to think this way? Why do we have this preconception?
I think that the preconception probably comes from events over our clinical careers that have either shocked us or been very memorable. It's the sort of 2 a.m. phone call about the patient with cirrhosis who is bleeding massively and the notion that we need to do something about it suddenly. And I think that imprints in our brains the notion that cirrhosis is a bleeding condition. If you look at textbooks, certainly textbooks until recently, they often say that cirrhosis is the epitome of the acquired bleeding disorder, and then the abnormalities in the laboratory tests, which taken superficially look like there's a net tendency to bleed, to just reinforce this preconception that's been there from these stressful emergency times.
What clotting presentations do we see, and how do we know that this is a problem?
Well, clotting presentations I think they're often overlooked in patients with cirrhosis because we often think that they're not there, but the thromboembolism is prevalent in cirrhosis, particularly thrombosis of the portal vein, which is a cause of deterioration of liver function and other problems in patients with cirrhosis. But they're also prone to thromboembolism elsewhere, as are other patients.
Why do you think that we see the two ends of the spectrum in the same patient group?
Bleeding, I think, is probably a consequence purely of portal hypertension itself. We know you can take patients with cirrhosis who have got bleeding from varices, and if you correct the portal hypertension but don't fix the laboratory abnormalities, then the bleeding will stop. So it's not this slight prolongation of the prothrombin time and the slight thrombocytopenia that's responsible for the bleeding. It's something else. Having said that, there is a tiny minority of patients with cirrhosis who have a significant acquired bleeding disorder with fibrinolysis and features akin to DIC, but that's very rare, and they will tend to bleed aggressively from venipuncture sites and things, and it's not the sort of bleeding that we tend to commonly see, which is portal hypertension driven.
And what's the mechanism of thrombosis?
Well, I think we'll talk probably more in detail about the coagulation cascade later, but there are abnormalities both of the pro and the anticoagulant factors in cirrhosis, and taken in combination with just the parts of Virchow's triad that we probably will remember from student days, changes in vessel walls and flow predisposed to thrombosis. Also the notion that certainly cirrhotic inpatients are sick inpatients, and like other sick inpatients, they'll have reduced mobility, they'll have sepsis, they'll be dehydrated, all the things that predispose anyone to thrombosis are important factors for them.
You mentioned the lab abnormalities. I think the reason people often don't think about thrombosis in patients with cirrhosis is the prolonged PT and this notion that patients are auto-anticoagulated. Can you explain the discrepancy between the lab results and the clotting or bleeding tendency?
Yeah, I think that's a very important point, and I agree completely. This notion of auto-anticoagulation is very prevalent. If you cast your mind back to the coagulation cascade from the far-off days of medical school, and it was the coagulation cascade that people tend to learn as students is complex enough, and people tend to learn the prothrombotic part of the pathway, but remember the pathway is a balance of prothrombotic factors as well as antithrombotic or fibrinolytic factors. And when we measure clotting in the lab, what we tend to measure is purely the prothrombotic side of things. So if you take blood from somebody to measure the coagulation, the blood will be mixed with a chelating agent to bind calcium. Usually either EDTA or sodium citrate. Once you've removed calcium from the blood, it won't clot. And then the laboratory add another factor back to stimulate the clotting pathway, either the extrinsic or intrinsic pathway. You add calcium as well, and then you start the stop clock and measure how long it takes the blood to clot. And that's a very simple, very reproducible test. But it doesn't tell you anything about the factors that predispose to fibrinolysis or oppose clotting, because those factors are all dependent on interactions with proteins that are normally present on the surface of the endothelium, like thrombomodulin, for example. And the levels of things like protein C and S, which tend to be low in cirrhosis as well, which act by interacting with these endothelial-bound proteins, are not measurable by standard lab tests. So we really only measure one side of things. What we tend to find in cirrhosis is that the pro and the anticoagulant factors are both low. And if they're both low to an equal extent, then you'd think that the chances of thrombosis are neither increased or decreased because of the blood constituents alone. And for an INR of less than 2, what we're probably just measuring is essentially lab artefact, if you like, and it doesn't imply any net tendency to bleed. And if there's a take-home message from our discussion today, that would probably be one of the messages. An INR of less than 2 does not imply a net tendency to bleed because of coagulopathy in these patients.
And is there anything in the lab parameters that does imply a tendency to bleeding?
Yeah, I think that's a good question. I think platelets are less than 50. Studies have consistently shown that if there's anything that predicts bleeding risk, that from the laboratory tests, it's low platelets rather than the prothrombin time.
What evidence do we have that patients with cirrhosis are at increased risk for VTE?
Yeah. Probably the best evidence now has been around certainly it's based on data collected around about 20 years ago. Large epidemiological studies from the US have looked at a stratified sample of hospitalised inpatients in America. And they looked at the discharge coding in such a way to identify patients who weren't admitted to hospital with a thromboembolic event, but who had a thromboembolic event when they were in hospital. And these typically would be the sort of events that we want to prevent in all our inpatients, and the ones for whom we commonly prescribe low-dose prophylactic low molecular weight heparins. And what they found is if you take patients with cirrhosis over the age of 45 and compare them to age-matched controls and try and correct for comorbidities, that the rate of venous thromboembolism occurring in hospital is no different between these two groups. But more interestingly, if you look at the under 45s, the rate of venous thromboembolism occurring in hospital was much higher. Now, we can speculate about why that might be. Despite their attempts to correct for comorbidity, it's likely that cirrhotic patients are less ambulant and are just sicker in general, particularly when they're young. Say, if you imagine, a patient with cirrhosis who's severe enough to be hospitalised at the age of 30, they'll probably be sicker than other hospital inpatients at age 30. But notwithstanding, there may be elements of the cirrhosis itself that are driving this thrombosis. Frustratingly, from the paper, it's you cannot tease out the type of thromboembolism that the patients were having. But just looking at the structure of the paper, the relative occurrence of different thrombotic events, I think they're not just talking about portal vein thrombosis, but they're talking about the thromboses that we fear or recognise in general hospital inpatients, deep vein thrombosis, pulmonary thromboembolism.
What should we be doing, do you think, in a hospital setting to reduce risk?
I think the key is really just to treat the cirrhotic patients as you would treat a non-cirrhotic patient and follow a protocolised assessment for thromboprophylaxis. Looking at the bleeding risk, looking at other factors, their age, their likely duration of hospital stay, whether they're ambulant or not, whether they have other risk factors for thrombosis or the risk factors for bleeding independent just of the presence of cirrhosis. And in most cases that will mean prescribing prophylactic low molecular weight heparin, and that's actually part of the Basel bundle for the management of cirrhotic inpatients, which says if you don't have severe thrombocytopenia and if your INR is less than 2, and unless you've reason to suspect active variceal bleeding, then it's appropriate to give low molecular weight heparins.
So I guess the clotting event that I associate most with cirrhosis is portal vein thrombosis. How common is it in these patients?
To give you a slightly complicated answer, is I think we probably don't see it as often as it happens. Certainly the rate at which it's happening in studies that have measured it seem to be going up. The overall rate at the moment in a recent study looking at all cirrhotics is estimated at 1 in 40. Although the rate of portal vein thrombosis probably increases as the severity of the cirrhosis worsens, and it's maybe 1 in 10 or more. There's other common complications of cirrhosis will increase the likelihood again, particularly hepatocellular cancer. If you look at the time trends, it looks like the rate of diagnosis of portal vein thrombosis, the relative rate is going up by 10% a year over the last 20 years or so. So we're getting better at recognising it, or we're probably getting better at picking it up incidentally on scans, the quality of which have increased over that time.
And is that how it would tend to present, or are there other situations when we should think about portal vein thrombosis?
I think it's useful to divide it into 3 groups. So you'll have, the first group will be asymptomatic completely, and they're often picked up incidentally on screening scans to look for hepatocellular cancer. So commonly the 6-month screening ultrasound to look for hepatocellular cancer will say there's a portal vein thrombosis, it wasn't apparent on the previous scan, or there's a branch thrombosis. The second set of patients will often present non-specifically, often with a decompensation in their cirrhosis. And it's easy to not look for a cause of decompensation of cirrhosis in general, and in particular it's easy to not consider portal vein thrombosis as the cause of that decompensation. The third group I think present non-specifically, often with abdominal pain, but again, somebody with abdominal pain, portal vein thrombosis is maybe not the thing that's first suspected. So I think for all these reasons you need a high index of suspicion that this is something that these patients are going to be prone to, and to look for a possible cause.
Would you advocate that all patients with cirrhosis that are decompensated should have an ultrasound?
I think that's reasonable. You'd often want to ultrasound them anyway to determine if there's something else like hepatocellular cancer that hasn't been seen, depending on when the last ultrasound was. If they're jaundiced, you might want to check for biliary obstruction. They often have coexistent gallstones. Again, I think you have to have a high index of suspicion for an obstructive biliary problem, which may not present in a typical way in these patients. So an ultrasound is useful. A CT will give you more information, so I think if there's any doubt, a triple phase CT is a useful thing to do. And I think if the ultrasound has shown a portal vein thrombosis or a suspected one, I think definitely going on to CT is a useful thing to do. And it will give you a hard comparison later on if you want to evaluate the outcome of treatment in terms of recanalisation of the vein.
What additional information do you get from a CT that you don't get from the ultrasound scan?
It will show you the extent of the thrombosis better than an ultrasound will. It will, particularly if the thrombosis is severe, it will show you any impending problem with the bowel, because venous infarction of the bowel is something to consider and be aware of in patients with an extensive thrombosis. It will show you hepatocellular cancer, again, as a potential cause, which you may see in an ultrasound, but you'll see better on a triple phase CT.
Are there any other tests that are helpful?
Well, in patients with portal vein thrombosis, we often think, would thrombophilia testing be useful? I don't find it particularly helpful in cirrhotic patients because they'll tend to have abnormalities of the lab tests. Anyway, if you do measure protein C and S, they'll often be low, and then you're left in a situation trying to work out, is this an acquired problem because of the cirrhosis, or is it the primary driver? Although there is some research interest in disordered problems to do with anticoagulant factors predisposing to advanced fibrosis, but that's or a rapidly advancing fibrosis, but that's really more of a research question. I think the thrombophilia tests are better in evaluating causes of non-cirrhotic portal hypertension, but that's probably a whole topic in itself for another day.
Having made the diagnosis, what are the principles of management?
I think a lot of the principles of management are similar to managing any thrombosis with anticoagulation. In other words, you want to establish what is the risk of the thrombosis itself and what are the risks of treatment. Now, obviously, the concern with liver disease from the imprinting of the emergencies we talked about early on would be the notion of bleeding. And although part of my message today is to say don't overestimate the bleeding risks, I would say don't discard it completely. And what you need to have is a a rational assessment, and that will depend on things like the cause of the cirrhosis, the lifestyle factors, are they at risk of bleeding for other reasons, such as they can be prone to trauma or falls or head injury. You want to assess if there's any clear precipitating event for the thrombosis, over and above the cirrhosis that's present. For example, is there any evidence of, say, a localised perforation or something in the abdomen that may predispose to a thrombosis in that case? Has there been recent pancreatitis? And then you want to look at the proposed duration of anticoagulation. I think one of the important messages is that you can have a range of very good outcomes with anticoagulation for portal vein thrombosis. It lowers the rate of variceal bleeding, and there's a recent good meta-analysis to demonstrate that. In the patients in the meta-analysis, in the control group, approximately a quarter of them had variceal bleeding, but that rate was reduced down to a quarter. In other words, about a 16th of the patients in the arm who were treated with anticoagulants had bleeding. So if you have a portal vein thrombosis, your risk of variceal hemorrhage actually falls with anticoagulation rather than rising. Your rate of recanalization in certainly acute or subacute or suspected acute portal vein thrombosis is around about 50% with treatment, and it's far, far less. It's vanishingly small in the absence of treatment. Although one problem is that on withdrawal of anticoagulants, the portal vein thrombosis will often recur, and it's difficult to know when to stop. There is a survival advantage to anticoagulation as well, and that's slightly nuanced as well, in that if you look at the survival curves of patients with portal vein thrombosis who have been anticoagulated, the survival advantage is best in those whose veins recanalize, in other words, where the thrombosis disappears. The group who seemed to do second best are the group who weren't treated at all, but the group who seemed to do the worst are the group in whom they were anticoagulated but they had no response to treatment. Now, it's probably too much to say that that's because of the risks of bleeding from the anticoagulation. It may be that they had more severe disease and that's why they didn't respond to treatment in the first place. The other thing to say is if you look at these survival curves, although there's a definite benefit to a treatment which works, the benefit isn't sustained infinitely. It's sustained for a period of months, and therefore the group that are probably most likely to benefit are the group in whom you have got a way out. Maybe the group in whom this treatment is a bridge to transplant or a bridge to something else, or there's a notion that somehow the severity of their liver disease can be improved maybe 6 months or so down the line, either by abstinence from alcohol or treatment for viral hepatitis. So I think when you're choosing who to treat, you probably want to have an idea of what your endpoint is likely to be. And if you can't improve things several months down the line, then that's something to bear in mind about whether you would go ahead and treat or not.
And that's an important shift, isn't it, in thinking? Not only can we anticoagulate patients with portal vein thrombosis, but doing that reduces the chances of variceal bleeding.
Yeah, I think that's a key message, that the risk of variceal hemorrhage is reduced. And that's probably because when the portal vein recanalizes, the portal pressure will fall. Yeah. And there may be other benefits of anticoagulation to do with liver function that we'll probably come to talk about later. But yeah, the risk of variceal hemorrhage goes down.
And thinking about variceal bleeding risk is an important part of assessment. How do you approach that?
In some ways, it's probably harder when you're considering a situation where you have a thrombosis that's not in the portal vein, because it's now well established that treating a portal vein thrombosis lowers your rate of variceal hemorrhage. What say you have a thrombosis in your femoral vein? Now, obviously, that's potentially very serious because you can develop a pulmonary thromboembolism, although there might be other treatment strategies you could employ regardless of anticoagulation. But if we took an example, say, of somebody with cirrhosis who's hospitalised, who has a femoral DVT, but who has, for example, medium-sized varices, then the question is, what do? You probably want to get on and treat them quite quickly. And if anything, you probably want to treat them more quickly than you might with a portal vein thrombosis, which doesn't have severe features, because you may have a little bit of time. But with a femoral DVT, your worry is always going to be that a fatal pulmonary embolism may be just around the corner. And in that situation, all other things being equal, and in the absence, say, of a severe thrombocytopenia or a severe coagulopathy, a very prolonged INR, I think anticoagulation would be appropriate, with the notion that you can go on and treat the varices. You can either start variceal treatment immediately by giving beta blocker prophylaxis, but if you need to band varices, then banding varices is safe in patients who are treated with anticoagulants. And there was a study last year which looked at using long-term low molecular weight heparin at treatment doses for thromboembolism, and they showed that you can band varices just by interrupting the standard dose schedule for 12 hours on the day of the banding procedure itself, and then restart 12 hours later without any harmful consequences. So in the example I quoted, I think I would treat with low molecular weight heparin, start beta blockers, non-selective beta blockers straight away. But if there's a reason not to beta block, the beta blockers were not tolerated, then I would go on to start a banding program straight away as well.
So in this scenario, we already know that the patient has varices, and in fact we have a risk assessment already, and maybe they're already on primary prophylaxis. What about the situation where they've not had a recent scope, or you don't know whether they have varices? How do you approach that?
I think I'd probably tend to anticoagulate unless there were reasons to suspect that they'd had bleeding or had bleeding recently. And again, I think I would assess them similarly to a non-cirrhotic patient. You're just trying to look at the bleeding risk in general, but just the notion that they have cirrhosis, I don't think is a strikeout. I'd look at the platelets. I think I'd be guided more by the platelets and by whether there was a notion that they may have had minor GI bleeds that had been unrecognised before. And I think you'd want to discuss the risks with the patient, but certainly if you're looking at femoral DVT, then you want to do something about that. And I think anticoagulation is appropriate.
So what should we use, do you think? Warfarin, low molecular weight heparin, DOACs? What do you think?
And that's interesting as well. There are a lot of studies that use low molecular weight heparins, a lot of studies that use warfarin. Personally, I find warfarin a difficult choice. And I think that's because I find it hard to take somebody with an INR of, say, maybe 1.8, 1.9 and say, when this person's INR is 2 on warfarin, I'm going to consider that they are appropriately anticoagulated. Having said that, there are studies which have said that if you aim for an INR of between 2 and 3 in this situation in cirrhosis, then your outcomes are as reasonable in patients without cirrhosis. And there are also studies that suggest that the dose of warfarin on average that you need to obtain this level of anticoagulation isn't different in cirrhotics and non-cirrhotics, implying that you could use the tests. My personal preference is to use low molecular weight heparin, but patients do find it difficult to tolerate low molecular weight heparin injections over a long period of time. There was one study in particular published in 2012 which more or less looked at what was being done in a real-life setting in patients who were being screened for hepatocellular cancer and in whom portal vein thrombosis was detected incidentally. And they didn't specify an anticoagulant regime because it depended on what the local hospitals did. The negative predictive factor in terms of bleeding in that situation, the factor which predicted bleeding was thrombocytopenia. And although not statistically significant, and although the trial wasn't set up to look at that in particular, it looked like the rate of bleeding was higher in the group that were warfarin treated. And I think for that reason I feel more comfortable with low molecular weight heparins as well. The jury is out on the novel anticoagulants at the moment, but there have been some publications which have tended to suggest that the outcomes are similar to warfarin. So on the one hand, they're not miracle drugs without risks. There is the specific risk of not having a readily available agent to reverse their anticoagulant effect, but they also don't seem to be worse. And I think that will be a very interesting thing over the next couple of years to see where we are with that.
Is there any variation in the approach to management depending on how the patient presents? I'm thinking, for example, of the acute setting versus, I guess, the chronic setting with portal cavernous transformation, or even that grey area in the middle.
I think that the situation where you need to do something most quickly is a situation where the portal venous anatomy in general seems to be under threat. So a massive thrombosis, not just in the portal vein, but extending into the splenic and the superior mesenteric veins. If there's suggestions in imaging that there may be impending venous infarction of the bowel, that all needs very urgent treatment. A symptomatic presentation, I think, is more concerning than an asymptomatic presentation. But also symptomatic presentation may give you a clue that this is something that is acute, and the more acutely you start treatment, the more effective it's likely to be. In the context of cavernous transformation, it is clear that the thrombosis isn't new. Now, that doesn't mean that you shouldn't anticoagulate, but again, your outcomes are probably less likely to be good, and you probably want to know what you're looking at somewhere down the line from here. In terms of, are you going to try treatment? How are you going to assess the response to treatment? Because as we've said, the non-responders are the ones who probably have a less good outcome. And is there something a few months down the line, like a transplant, that you're hoping to get people to?
And how are you going to assess response to treatment in patients who are anticoagulated? And as a second part to that question, how long should we continue treatment?
Well, I would re-image them automatically, probably say 3 months, again, depending on their clinical presentation. But I think if somebody had, say, an incidental portal vein thrombosis detected on screening imaging, I would offer them anticoagulation and then re-image them by CT at 3 months if they'd had a decompensation that we thought was a consequence of an acute thrombosis. Again, I would treat them for 3 months and then see. I might want to keep the treatment going for longer if they were, say, on a transplant waiting list. If there was no defined endpoint, then with the notion that the thrombosis has got a high chance of recurring, I would probably offer to them that they might want to switch to a sort of prophylactic dose of, say, enoxaparin. Again, with the notion that they usually tend to find the injections quite unpleasant after a period of time.
And is there any way to prevent portal vein thrombosis in patients with cirrhosis?
And this is one of the most interesting developments in the role of looking at anticoagulation in liver disease. And it's interesting if you look at the role of anticoagulation in all diseases, say cardiac disease, for example, we over the years we've tended to become more pro-anticoagulant, if that is a thing. And I think we're seeing that developing in liver disease now. The landmark study in this area was published in 2012. It involved taking 70 patients with cirrhosis who were all Child's B severity, who did not have a history of decompensation before, splitting these 70 patients into 2 groups, one of whom received sham injections and the other received enoxaparin, a prophylaxis, a sort of standard prophylaxis dose. They were followed up for a year on treatment, and then at the end of the year treatment stopped, and they were followed up for another year beyond that. And they showed that first of all, that the treatment was well tolerated. There was no significant excess of bleeding episodes in the enoxaparin-treated group. But the rate of decompensation was much less in the treated group, and they defined decompensation usually as the development of ascites. And from memory, I think the rate of decompensation was approximately a third of the control group, but approximately an eighth of the enoxaparin-treated group. And there was a mortality advantage as well of approximately a 50% reduction in the mortality rate in the treated group. And the benefits seemed to extend out into the second year of therapy when the patients weren't treated. That's generated a lot of interest in that study, not least about why this should be. I should say that portal vein thrombosis was prevented in the treatment group, but the survival advantage seems to be beyond just the prevention of portal vein thrombosis, and it could be either prevented thrombotic events that wouldn't normally have been detected, maybe it improved the intestinal microcirculation, which we think now is important in the role of decompensation of liver disease. The whole notion of having a leaky portal circulation leading to downstream liver problems. There is the notion that portal thromboembolic phenomena may be important in causing decompensations in liver disease. It may be that, and we know that the portal vein can recanalize quite rapidly in some situations, if the thrombosis is not severe. And it may be that portal thromboembolism is important in these episodes of decompensation. And we know in patients with non-cirrhotic portal hypertension or non-cirrhotic intrahepatic portal hypertension, that portal thromboembolic phenomena are important in generation of liver diseases, for example, nodular regenerative hyperplasia. But I guess more work is required, is what people have normally said on reviewing that study. But it's certainly interesting and important. And if you have a patient in that category, which will very often be patients who are being assessed for transplant, given that it was in the context of patients with Child's B, that the survival advantage for even a period of months could be very important to this group.
And are there any key messages then that you would leave us with?
I think the key thing is, just because somebody has cirrhosis, don't consider them or don't deny them thromboprophylaxis just because of the cirrhosis alone. Make a rational assessment about their bleeding and thrombotic risk, but the presence of cirrhosis alone should not be a strikeout in terms of offering them thromboprophylaxis. Don't assume that patients are auto-anticoagulated, and to be honest, I think an INR of less than 2 can generally be disregarded. And I think that's true of an episode where somebody's actively bleeding as well. I think if the INR is less than 2, I'd be more concerned about what the platelets were in somebody with active bleeding. And the final message is probably to seek to have a low index of suspicion for and to treat portal vein thrombosis in patients with cirrhosis, particularly if there's any evidence of decompensation.
So all that's left then is for me to thank you for a fantastic update on an important topic, and to thank you for joining us for Digest This.